Excellent. It's great discussion. I want to follow up on another question that was in the chat regarding the remote patient monitoring and how you all are implementing that. Are you implementing that, and how that's kind of working?
This is Dr. Singer, and that was my comment. And I know, like, our home health got 18 home monitoring systems, and we're just kind of letting people know that's available, and then willing to ramp that up as they're being used. We just had a lot of comments from our primary care saying that people didn't have a way to monitor, and so hopefully this will help with that need.
So this is Ruth Christopolsky. We actually set up a virtual hospital. And so we've been managing somewhere between 500 to 600 patients on a daily basis. Some of them using remote technology. So for individuals that were at a higher level of care, they actually provided kits that included blood pressure cuffs, thermometers, scales, and pulse oximeters. And then we have a center, a remote monitoring center where all of that information was coming into, and then using nurses monitored that, had clinicians, physician clinicians actually round from a hospitalist kind of standpoint in the morning and at night. And for our patients that needed more help, we did about 500 home visits using paramedicine and RN. So we've been really testing the boundaries of what we can do with remote monitoring and how we can manage people in their homes, particularly COVID positive patients that need some additional assistance to try to prevent the spread across the broader population.
What's been the patient response to this?
They love it, right? Like, they have a number one, they can rest, right? They rest better in their own homes than in the hospital. And because we're only bothering them every, Q4, Q6, depending on their symptoms, when you're in the hospital and you're trying to sleep, a lot of times there's external noise. You're not in an environment that you're comfortable in. Most of the folks didn't have any problems with the technology. We did, though, use the patient's ability to manage at home and then have caregiver support at home to determine how we would roll it out. But we got all really positive feedback from the patients. They like being in their own homes.
I'm not sure who just spoke, but I'm just curious what area you're from and whether you see that being a part of your future as well.
Yeah, this is Ruth Christopolsky. I'm from Atrium Health. And yeah, we're actually looking at, we had been talking about kind of hospital at home for at least the last 2 years, but, didn't have any payer support, and there wasn't a pandemic to kind of push us in that direction. We did some work kind of in the advanced illness management and some home palliative care work, but not really managing a more complex patient that needed ongoing medical management in the home. And so we are looking right now on what are the subpopulations within, quite frankly, our value-based contracts where we can continue to use the service to manage, some of our more fragile medical patients that would be successful at home. So really, really excited about kind of learning and the opportunity. I think over the COVID timeframe, we managed a little bit more than 2,300 patients this way, and less than 5% of them actually had to be admitted into a bricks or mortar facility. So worked, I think, better than we thought it would.
And those patients you didn't consider hospice patients. I'm sorry if you already said that.
Oh no, these were active COVID positive patients that needed medical management, right? So they would be what we would typically consider our lower level medical patients.
Like on med surg floor or something?
Like a med surg floor patient, yep.
What was your fatality rate for those? Did you say 2,300?
Nobody died. No,
Wow.
none of the patients that we managed that way passed away, but about 4% actually had to go from being managed at home to actually being admitted to the hospital, which I would still say is pretty successful.
Really? That's impressive.
Anybody else have any questions or comments in this discussion area? Is there anything that we haven't talked about regarding like either, or virtual visits in general, and of course the, remote monitoring that has been challenging or that has worked really well for your organization and patients?
This is Mark from UNC. I'd love to pose a question to the group. As part of our integrated network in ACO, we have a pretty significant quality improvement coaching team and at the elbow support for practices, and in other words, lots of in-practice support that we've instituted over the past couple of years. And we're really trying to figure out how to continue that, but perhaps remotely. So it's not virtual patient care, but it's virtual management of a network. And I'm just wondering if anyone has thought through that and has any creativity around how to do that well, what used to be at the elbow support to do virtually.
We have our care management centralized. So for us, it was not a big deal to transition that from home. It's always worked quite well for us. I mean, I don't know what specific things that they're doing at that point. A lot of it's telephonic instead of in the room with the patient. But the patients, since we've started that way, the patients have responded well to it, and they seem to like that, and it's been successful for us. If you have a specific concern, I could answer that maybe.
I was kind of questioning too, if you could give an example.
So, I was thinking more about, to agree that for our network, we have a mix of centralized resources and embedded resources. So care management is one, behavioral health is another. Those are relatively easy to transition to virtual health, which we've done. I'm thinking more about clinical quality improvement, and as we transition back to paying attention to specific quality measures, historically we've deployed a lot of resources into practices to review data, use lean management principles with visual management and gap assessment and tracking and coaching practices and staff to do that kind of work differently and better. And I don't know how much how much time we're going to spend on clinical quality improvement in the next 3 months, but pretty soon we're going to have to, depending on our payers. So I'm more talking about that.
So we have standing orders for our care coordinators to be able to order colonoscopies, mammogram, set up pap smears with the providers, things like that, for those quality measures, for things that they might be missing, like a microalbumin or Pneumovax or something like that. A lot of times we'll put that in chief complaint on the next visit, so that the providers see that at that point. Is that the kind of stuff that you're talking about?
Yeah, that's helpful. Thanks.
Anybody else have anything to add to that or to ask? That's a good segue into kind of the next discussion topic that we've kind of thrown up, as far as where would you guys like to see the future of quality measurement head, and how this current COVID situation may affect that. And I'm curious where you think telehealth may configure into that, or if it will.
This is Donna Pryor from Pinehurst Medical Clinic. I'm not sure this goes right along with that, but I know one of the quality measurements that we've looked at and batted around for years has been keeping patients out of the emergency room. Things like what you call the lane visits, low acuity, non-emergent. Well, I can tell you that COVID has done that. You know, we haven't come up with any, great solutions, but COVID certainly has done that. And I'm wondering, how can we keep that momentum going, and what can we do to kind of build off of that? Because clearly, I mean, we know that there's data out there that some of these chronic patients are showing up in the emergency room now and have waited too long. But there's a large percentage of those lane patients that go with the earache or whatever. And I'm just wondering if, other people have been thinking about that and wondering, how do we kind of keep that going?
I don't know, but if you figure it out, I would love to hear it.
This is Annette. I guess my only thought is, like, this is part of why, we really hope that telehealth sticks for both patients and practices, and, really that we emerge from this with very different ways of thinking by all parties about, like, I can access my primary care provider conveniently and right now, and that there's efficient, work streams in the practice to accommodate that. I really believe it could be a game changer for unnecessary utilization and all kinds of other things.
I think we need regulatory and advocacy support both at the state and federal level, though, to allow us to continue to collect information and then use that information in things like risk adjustment and meeting some of the quality criteria. Because even if we can provide an alternative way to engage patients, if that doesn't count for checking a box for attribution or coding or collection of a quality metric, it still forces us to bring people into the office. So I think we also need the alignment with, some of the regulatory and compliance things to allow us to engage people where they're at and still get credit for the work that we're doing if it's not a face-to-face visit.
My understanding was that as long as you had a telehealth visit with a video component,
Sure.
It would count for RAF scores.
In the current, I was talking more long term.
Gotcha. Okay.
In the current environment, underneath a pandemic, we can. But I mean, if we want to take what we've learned through this and engaging patients and getting rid of some of those lower level visits and really being efficient, we need to be able to use technology to help us do some of that work and still get credit for it. And not just payment credit, but also credit towards quality and other things where historically we've been forced to be face-to-face in order to have that happen.
Oh, absolutely.
And some, like, very specific fine points in terms of policy advocacy on that. One is allowing AWVs via telehealth and including very clear guidance around the requirements around height, weight, BMI, and blood pressure, and whether those make sense for the broader mission of the AWV. Could this be an opportunity to move for the payers who are still measuring blood pressure control, really get some action about patient self-reported blood pressure and how to utilize that, both in better clinical care and in meeting the metric. And one other, really weedy tactical thing that might be interesting for this group to be aligned on is it'll be interesting to see what MA plans do with STARS cut points. And how that filters through to ACO contracts, because there are nuances in terms of the timing of how cut points are derived for the plans versus how they're derived in ACO contracts, and plans will get relief, COVID-related relief on some of their STARS incentives that would be good to, you know, it would be good if provider ACOs could collectively advocate for similar relief and how that is expressed in our contracts. If that makes sense.
I know there's some state legislators in our region who have a belief that telehealth is going to actually add costs to the care of Medicaid patients and Medicare patients, and oppose the expansion of telehealth related to that. So I think whatever we can do to educate our legislators on the potential positive impact on costs related to telehealth, that would be very beneficial in terms of getting some of this policy changed.
Amy, have they, are you familiar with any like specific details as to why they are concerned about that?
I mean, what I've heard, and I have not had a specific conversation, but I know actually our medical society leadership is engaging in that conversation. It is a belief that there's just going to be more care provided, that we're just going to do more visits, but not really understanding that it could impact higher cost utilization. So yeah, I mean, I think that for people who are outside of healthcare and don't really understand these dynamics, I think it's very difficult to understand. They're just not opening another door for people to bill more fee-for-service visits, you know.
So this is kind of a broad question, which I apologize, but as far as the data that you guys are paying attention to right now around, I guess, telehealth and kind of the impact that, or to your point earlier with the ER visits being, or for low acuity being down, telehealth visits being up, but now are starting to plateau a little bit. Are you guys keeping a focus on that comparison between the two and any other factors that would play into that? You know, so that as far as like looking down the road, how that would help from a regulatory or potentially regulatory standpoint and having that data.
I mean, one of the things that, and I've had this conversation with several, this is Ruth Christopolsky from Atrium. I've had this conversation with several folks in the policy advocacy space, as well as state legislative space. And reality is, if you don't bring someone to the office, you can't run a lab test or do any imaging on them, right? And so right away, the overall quote unquote cost to the system, if you're thinking about it from a fee-for-service standpoint, even if you can do more of them, you can't add anything to it. And so it's a relatively small lift. Now, there are some national studies that have shown that access goes up, or there's an increase in utilization when there are telehealth visits in the number of visits, but it never looked at the total cost of care, right? And so I think they're worried about a net increase in the number of interventions, but not really understanding that those interventions have a positive downstream effect. I can tell you, in my community-based clinics, which deal with our, uninsured, underserved, and Medicaid populations, the addition of telehealth has dropped our no-show rate by more than 50%. So the patients that we're engaging with in those populations are actually touching us more. So in a fee-for-service system, that's probably a bad thing because they're actually showing up for their visits. But in reality, they're some of the highest needs, most vulnerable patients, and so we can have the best impact on them. And so I think if we talk to the legislature about also creating access for individuals that have transportation and other needs, particularly those in our rural and underserved communities, I think that's another lane to go down, and not just the cost lane.
So Annette, that's a good point that you just put in the chat. You want to expand on that a little bit?
Sure. So I think I'll just read my own comment. There is a real concern that telehealth can be misused and overused, just like any other, fee-for-service thing. And there will be more and more people, entities out there trying to make money on how easy it is to bill a telehealth visit. So there's a real risk that could further fragment care and steal attribution from entities who are trying to actually do true continuity of care. And so, I think advocating for extended coverage policies within for providers that are actually in a total cost of care accountability framework provides some cover for that. And the other thing I was about to type up that I'll just say is that there's also a real concern that payers see this as an opportunity a convenient opportunity to provide a service to their members that totally disintermediates the patient's true care providers. And so that's another, thread of advocacy that would be a real shame if we see a lot of direct payer engagement with third-party vendors around remote patient engagement that further contributes to fragmentation of care.
Along that line, the other, I guess, issue I've heard with parity is you can set up a whole telehealth program where there's no brick and mortar overhead or anything like that. And so their argument is, well, we should pay less for that as opposed to an in-person physician visit where you've got a building, you've got staff, you've got all these things that, and for most of us who are in a sort of a hybrid situation where we've got all the overhead, but we're also trying to give televisits, that is a difficult position to take less for those visits.
Ms. Mark, the analogy is primary care, right? I mean, paying increasing access to primary care, yes, on face value will increase upfront costs just because there are more providers and more patient visits overall, but it absolutely prevents downstream cost, decreased hospitalizations, et cetera. So in talking with legislators, that's one of the arguments that has started to land a little bit, and also with some of our payers. I don't know if y'all think that's a valid argument, but to me, it's very, very similar analogy.
So Mel had a question in the chat that what are the efficiencies that practice facilities gain by using telehealth that, in conjunction with the fact that you can offer in-person visit as well, so that's not one or the others. Currently it might be a little bit more, but as far as moving ahead and looking into the future, these are visits that you can offer patients to the point of having a bricks and mortar, which you're going to need to have for the in-person, that you're also offering telehealth in that patient staying with their provider and continuing to build that relationship within the medical home. So beyond that too, what are some of the additional, I guess, efficiencies and pros that you guys see?
Definitely speeds up care, especially for people who are working. If you can just take any appointment and, have access and not leave not have to schedule a time where you can, it's near lunch where you have to leave the office, everybody wants the 8 o'clock spot, the, 12 o'clock spot, the 1:30 or 1 o'clock and the one at the end of the day, kind of a thing. So you could do any time that you have a, whatever period of time break that you need, hop online and be seen. So for the patients, there's a huge convenience factor. For society, that's a huge convenience factor and economic factor. And, there's some advantages of seeing how a person lives, their home, that kind of thing. You can have them look at things and within their home and, family members a lot of times, and the ones that I've done for the older folks, the 85-year-old isn't setting up the televisit, their daughter or granddaughter, whoever's there. And a lot of times you get some additional history items that, if they weren't there at a regular visit and they were sitting in the car while, grandma came in, that may have not been available. So, I mean, it's been very interesting, I've thought, doing the televisits. I think there's place for both. I wouldn't want to all do televisit, but it's been remarkable the things that kind of get uncovered and stuff in some of these televisits.
Agreed. It's been amazing. I've met a lot of families' pets.
I had an annual wellness visit probably 2 months ago that I was talking to the patient about handrails and, on stairs and all that kind of stuff, falls prevention. And they were sitting out, it was a trailer with no stairs after they told me that, they had handrails. I just kind of looked back while I was talking to them because they were sitting there on the thing. And I was like, so about those handrails, I'd never known, I didn't know what their living situation was like.
I would add that, one of the efficiencies already mentioned was that you don't have very many no-shows. And particularly now that everybody's at home, has been at home with COVID-19, you're going to talk to people if they've signed up for a visit. And if for some reason they don't answer, it's a lot easier to navigate around working them in later. If you can just leave a message and call them later and get them set back up. So you have a lot fewer missed appointments. And the workflow on your medical assistant side is so different. Like you don't, with patients who have mobility issues and are coming in and getting through the clinic, sometimes that takes quite a bit of time. Or if, anything else is going on and you're trying to figure out whether to send them to the lab first or whatever, there's just a bunch of potential workflow delays that make you end up having to wait on your medical assistant. That has all disappeared. And, sometimes my medical assistants have checked in way far ahead of when I'm ready for my telehealth visits because they just they're just so much faster than they used to be when you have to walk a patient into a room and, go through a variety of different steps. Of course, there's things missing from the visit because of that, but that makes it much more efficient.
So I know Mark touched on this, and I was going to ask about it as far as the how telehealth can help to improve some of the challenges we find with social drivers of health. Access being one, of course, transportation, which helps to strengthen an advocacy position. What are some of the other areas, outside of the ones you guys have just mentioned, very specific to the social drivers that virtual care can lend itself to?
When we get outside of primary care and we start to think about specialty care, it offers an opportunity to actually put specialists in parts of the state where it's really hard to support a live body person, right? And allows us to use, some of our higher needs specialists, like such as pulmonology or endocrinology, in a meaningful way across the broader footprint. The one thing that we hear over and over again from our patients is they like the fact that they don't have to drive an hour to an hour and 20 minutes each way, find a place to park, navigate a campus or a building, right, to get in. And so I do think there's the thought process of taking care to the patient versus forcing the patient to come to care. And we should highlight that as an opportunity, especially in cases where it can, where it's not, is one better than the other? It's when you don't have that capability of connecting virtually, you have no ability to connect with the patient at all. So I see it as an extension and in addition to, not instead of.
And this is Lydia Newman at New Hanover. I have to think having eyes in the home gives insights on care needs that have been discussed somewhat already, that you don't ever otherwise get, right? So if you think that your medication list is clear to the patient, they know what they're doing according to the care plan, and then you can witness them show you their med boxes or how they take their meds, or that they don't have food in their fridge, or all of that information is so informative to the care plan.
That's excellent. Thank you guys for that. Any other questions around that? I know we kind of got way off topic with the quality measures, but this is really, really great discussion, and I appreciate that. Kind of going back to the quality measurements and how we can, how do you see that shifting moving forward? Since they put some, there's kind of a reevaluation happening right now with CMS on that. So just kind of wanted to get your thoughts a little bit more on how we can help advocate on your behalf with that, with, you know, from the quality measurement standpoint.
I think sometimes quality measures are used to promote helpful practices, and I now I kind of feel like what we've learned in the last few months is kind of like, I can't imagine practicing medicine without a chronic care management team in the past, and now I can't imagine practicing without the telehealth opportunity. And so how could we make quality measures, you know, something like that, like in systems that are looking at the total cost of care, that could be a quality measure. Like, do you have telehealth available? I love the virtual hospital. You know, instead of the only option for someone that can't go home for post-acute care, could it be a quality measure of, you know, do you have it available to do virtual hospital care or virtual SNF care? So, because that's could be a really important thing for patients, and maybe a little bit more important than a Prevnar, you know, or so to have those options.
Hi, this is Cindy with Caremont. We're seeing with patients that we're outreaching to is that they are not wanting to come in to actually have some of the more invasive type testing done, particularly like a colonoscopy, in part because they have to go through the COVID screening, and of course everybody's heard how horrible that is. And so we have, we're kind of concerned about that for this measure year because, of course, you know, for 2 to 3 months we've been shut down and not able to perform any non-essential procedures. And now that we're just now allowed to start getting back to that, patients don't want it because they're either just afraid to come into an area where they know there are going to be some positive patients because it's attached to a hospital, or they just don't want to have that testing done. So does anybody have, like, what are your plans as far as moving forward with some of that more invasive type testing or testing that's literally attached to the hospital?
Hey, this is Ruth Kristopolsky. I can speak specifically to colonoscopy and colorectal cancer screening because we just had this conversation yesterday and the day before. So one of the things our quality team did was poll all of the individuals within our population that had in the past had either Cologuard or an FOBT test. So starting with not assuming everybody needs to get a colonoscopy to get credit, but looking at some of those other non-invasive and ensuring that we make that an offering to them, including we send kits into people's homes so they don't even have to leave their homes in order to have those done. And then for individuals who had colonoscopy and are ready for new ones, we're actually offering the other options. Now, we did have to work through our GI docs and through a lot of primary care to say a test is better than no test. And then who would be the people that would be most likely to engage in testing in a different way? And the very first group of people you go to are those that have already been tested that way. So that might be one way to look at the data. I don't believe we're going to get a lot of people, whether you're connected to a facility or not, to come in for invasive colonoscopy from a screening standpoint in the near term. So what are some other ways to fulfill that measure? So we try to use some of those other ways.
That's
we typically
perfect.
give till November for the providers to try and get everybody they can to get a colonoscopy. In the last 2 months, one of the things our care coordinators do is get people set up with Cologuard or FOBT to kind of get something done, if you will. Some of the MA plans and things like that also will send out occult blood kits if you ask them to. But I'm in the camp that also, get the colonoscopy if you can. So we try to push the colonoscopy as much as we can. And the care coordinators have a little more time to kind of coax people along. So that's one of their tasks in our group.
That's perfect. That's definitely, those are a couple of options that we're actually looking into. I just didn't know if anybody else had any other any other plans for things like that.
Excellent. I'll bring it back around. Just a question that I missed earlier and was touched on, but didn't really expand on, is kind of back to the parity. I think Mel was the one who asked about this, as far as whether having 100% parity would be, well, more so whether we would be willing to accept, a little bit lower than 100% parity, but between that maybe 85, 90%, or whether that would be unacceptable. Like, how do you guys feel about that or stand?
Primary care is pretty low margin. I mean, if you've got a brick and mortar place with the staffing that you have to staff, it's difficult to take less. I mean, what will end up happening if that happens is, I guess probably the PAs and nurse practitioners will do the televisits, is how the system will probably compensate if they lower the payment.
Do you have an idea of approximately what the percentage has been prior to COVID, what the percentage was for telehealth compared to office visits?
Oh, for like Medicare, it was like $14 or something. I mean, it was ridiculously low to where it wasn't even like really worth doing. They tripled it initially, and that was at like 70% of office visit. When they tripled because essentially what the telephonic visits are triple what the original televisits were for Medicare.
And this is Stephen Knuckles. For the commercial plans, they used to reimburse around, I think it's $40 to $50. And once again, that's probably about a half to a third what you would get from other commercials. So it was very low reimbursement.
And it's not particularly faster, so.
And they were encouraging too for you to have to use their telehealth platform versus if you had one of your own, correct?
Correct. Most of the groups I spoke to that were early adopters of using those CPT codes and those other technologies they were huge loss leaders. They were trying to get people in for other systems or other purposes. It just wouldn't work in a fee-for-service world.
That's our experience also.
I feel like that's a big area for a push as well, beyond just the parity, is really, again, trying to keep the patients with their medical home and being able to use that platform. Obviously that would be compliant, but it seems to be another big area for, again, advocacy. So let's see, we had another question come in. Lydia, I believe that's you that asked that. As far as if any ACOs are willing to share the standing orders they have for case managers to close care gaps.
Essentially, they're just the criteria for the screening tests. So like, if a woman's age 50 to 75 and had a mammogram in the last 2 years, you can have a mammogram in the last 2 years. Same thing with, colonoscopies, the cold bloods, Cologuards. I mean, they're just the United States Preventive Services Task Force recommendations in a order form is what we use.
That's great. Thank you.
Any other questions that anybody has? I know we're getting close on time, and I'm interested in hearing what you guys see as far as the opportunities for value-based care post-COVID as well. But I want to make sure that there weren't other questions that anybody had, or any of the ACOs we haven't heard from yet. You guys had anything? Okay. Well, then to kind of the last discussion point before we close out today, where do you guys see some of the opportunities for value-based care? I mean, we've touched on some, of course, but post-COVID, within our system, our health system, we'll focus on North Carolina, but where we can focus our attention and efforts. All right. What about as far as...
Hey, Kristen.
Yes.
Sorry, this is Mark from UNC. I'll say something. Two broad comments. One, for those of us that are aligned with a larger healthcare system, our value-based work is a hedge against the fee-for-service losses that healthcare systems are experiencing significantly. It's pretty, it's reassuring to be able to say that through, a CMS ACO, that we're likely to see X amount of millions of shared savings in a year, that our healthcare system is likely to lose 100 million or more. So that type of argument, I think, is really powerful for our systems to continue to invest in value-based care, in alternative payment models, and to continue this work. So I'm actually really reassured that we'll continue our efforts for the foreseeable future, and that is very reassuring. Secondly, there's such significant uncertainty in how 2020 will affect future future year benchmarks that I think we have to start thinking a little bit more creatively about how to partner with payers around total cost of care models. And perhaps this is an opportunity that we can really accelerate this and move past simple shared savings arrangements to something more global. And I think that there's a potential real opportunity for us to catalyze all of our efforts in that direction. I'm assuming most people agree that's the right direction to go, but this could be a real opportunity.
I'm curious to hear what some of the organizations that are not already in a risk agreement, if we were to push this, if value-based care was to be pushed forward a little bit more aggressively, which of course would mean taking on some risk, at least most likely, how you see that, or what your perspective is on that at this point.
This is Ruth from E-Train. I think depending on the underlying organization that's taking the risk and the capacity of the participants to take on risk, particularly independent clinicians who may have not had a historic large number of risk-based agreements to kind of hedge against the impact they've had over the last 90 days. I think the ability to move quickly for some people will be hard just because of the financial situation they're in as a result of COVID. So I do see it kind of as a hedge. There's this excitement about the opportunity to move, but I also do think for some of our independent providers who may not have, that are not well capitalized and may not have, underlying capability to take on large levels of risk, I think there's still some apprehension and fear.
Ruth, this is Mark again. That is an absolutely terrific point. What has also become clear is that for systems, the survivability of the local community-based networks becomes increasingly important. Meaning, we need our independent practices, one, to stay independent, and two, to stay healthy as much as possible, so that patients still get good primary care and don't end up in the emergency department, for example. So I think there are aligned incentives here for larger systems to continue to help community-based practices and even absorb some of that risk moving forward, more so than systems have been willing to do in the past. I think there's a real opportunity there.
So Kristen, this is Alyssa. I'll make a few additional comments, and I totally agree with everything that was said in terms of, hedging against what's going on for our hospital partners. But I really think this is a great opportunity for us to look at sort of redesigning care, and I think people touched on it earlier about meeting patients where they are, doing more services at home, in the home that we could possibly do, as well as also educating our patients, because they are fearful right now about coming back in. And so really educating on, appropriate use of the emergency room. And I saw the chat box comment about the Call Us First campaign, and
we're also looking at doing that as well. We've had meetings on that and have a meeting tomorrow to talk about it, but where we're going to have buttons for our practices and try to educate patients to reach out to our practices first. So I think we're sitting in a great position to really change the future and help redesign how care is delivered. So I think it's a really exciting time for us, and especially all of us who are focused on value-based care.
Thanks, Alyssa. Anybody else have anything they want to add, any questions or comments before we adjourn? Wonderful. Thank you, guys. This has been a phenomenal discussion, and greatly appreciate all of the conversation and good points or all the excellent points to make. We did record this, so we'll try to figure out a way to provide that for you guys. And just want to make a quick comment regarding the next meetings. We have the Population Health Collaborative in September. I'm trying to get my, what is that, September 10th. And then the next ACO Council meeting is November 12th. And obviously there'll be more details to come exactly on how we will proceed with that, whether it will be virtual or if we'll try to do in person. But as of right now, it'll probably be another virtual meeting potentially. So we would love to hear your feedback as far as how today went. And if you guys have any additional questions or comments that didn't get addressed on the call today, please feel free to send it to me directly, and I'll make sure to dispense that out to everybody else. And thank you guys all. Hope you all stay safe, stay well, and have a great rest of the week and weekend.